The spinal cord, unlike the brain, has the gray matter inside and the white matter outside. So if you see in the cerebral or cerebellar cortex, the gray matter is outside, but the white matter is inside. Whereas in the spinal cord, it's exactly the opposite. So you can see over here that the gray matter is like a clover leaf like structure, and it's present centrally. So you have the gray matter over here. And around this gray matter, you have the ascending and descending tracts. So let's have a look about the distribution of the white matter pathways first. So over here, posteriorly, you have the area which is very fondly known as the posterior column. So this posterior column is important for carrying joint position sense, proprioceptive information, pressure, as well as vibration. And this posterior column is split into two white tracts or fasciculi. So one is the fasciculus cuneatus, which is present laterally, and then we have the fasciculus gracilis, which is present somewhat medially. And the lamination of the posterior column fibers is in such a way that the cervical fibers are lateralmost and the sacral fibers are the medialmost. So this is how it is for the posterior column. It is exactly opposite in the spinothalamic tract. So the dorsal column, it is exactly opposite when it comes to the pyramidal path, which we'll have a look right. So over here, yeah, sorry. So over here you can see that this is the posterior column. Next is we have the dorsal spinocerebellar tract, and over here we have the ventral spinocerebellar tract, and over here we have the lateral spinothalamic tract as well as the anterior or ventral spinothalamic tract. Okay, so the spinothalamic tracts are very, very important in the sense that they carry both pain as well as temperature. And carry pain as well as temperature. So as I was mentioning earlier, the lamination of the spinothalamic fibers is opposite to that of the dorsal column. So the dorsal column, the sacral fibers are medial and the cervical fibers are lateral. Whereas in the spinothalamic tract, both the lateral and the anterior, the cervical fibers are medial and the sacral fibers are lateral. All right. Then you have other extrapyramidal tracts. You have the tectospinal tract. You have the ventral reticulospinal tract. Here you have the vestibulospinal tract. And then here we have the lateral reticulospinal tract. So this reticulospinal tract, both lateral and ventral, the vestibulospinal tract, as well as the tectospinal tract, are important for axial and proximal limb movements. And over here, we have the corticospinal tract, the anterior corticospinal tract, which is not crossed. So as you know that most of the corticospinal tract or the pyramidal tract crosses at the level of the medulla. But there is a small percentage of the pyramidal pathway that does not cross at the medulla, but actually crosses at a segmental level. This is known as the anterior or ventral pyramidal pathway or corticospinal tract. This is responsible for distal movements. Okay, it's a very minor role for distal movements, but the majority of the distal limb movements is from the lateral corticospinal tract. So these lateral corticospinal tract are basically the cross pyramidal path. So the pyramidal tract which crosses in the medulla enters the white matter of the spinal cord as a lateral corticospinal tract, which has a majority role in distal limb movements. The ventral or uncrossed corticospinal tract is more for axial musculature. It's more for axial musculature. It has a very minor role for distal movements. And the ventral corticospinal tract only crosses at a segmental level, not at the pyramidal level. And another smaller tract is the rubrospinal tract. You have the rubrospinal tract, which is also responsible for distal limb movements. And over here in the center of the spinal cord, we have the central canal. We have the central canal. And in the anterior portion, we have the important part of the gray matter that is responsible for motor movements. That is the anterior horn cells, okay, which has majority of the motor neurons. And from the dorsal gray matter, it's predominantly sensory. So the dorsal gray matter predominantly serves a sensory role, whereas the anterior gray matter of the spinal cord predominantly represents a motor role. And here, the gray matter of the dorsal gray matter of the spinal cord then continues as the dorsal root. Then the dorsal root ganglion, and after that, the sensory fibers. So this is about the lamination of the spinal cord, the important cross-sectional anatomy of the spinal cord. So let's go into the other relevant clinical anatomy of spinal cord. So the spinal cord starts from the end of the medulla and ends at the conus medullaris. So it is from the medulla till the conus medullaris at the lumbar vertebral level. And there is a fibrous extension at the end of the spinal cord, which is known as the final terminal that terminates at the cortex. Spinal cord is totally 46 centimeters long. This is an important MCQ question. And it has two enlargement, one at the cervical region and one at the lumbar region. This is very, very easy. The reasons for these enlargements is because we have the cervical enlargement for the upper limb innervation and we have the lumbar enlargement for the lower limb innervation. Cervical for the upper limbs, lumbar for the lower limbs. All right. So as I already mentioned, the in the spinal cord, the central part has the gray matter, and it's basically a four-leaf clover structure. It has a like a clover leaf-like shape, and that is surrounded by a central canal. Okay, so basically, it looks like a clover leaf, and centrally there is a central canal. And the central canal is basically just an anatomical extension of the fourth ventricle. And as I mentioned, outer we have the white matter. And just like how the brain is covered by the meninges, here also the spinal cord is covered by the pia matter, arachnoid matter, as well as the dura matter. And there are totally 31 spinal segments. There are totally 31 spinal segments. There are totally 31 spinal segments. And each spinal segment has an exiting ventral motor root that that gives motor information to the muscles, and an entering dorsal root that relays sensory information from the distal from the areas of innervation. So anteriorly it's a motor function, dorsally it is a sensory function. And another important thing is to understand that the spinal cord level and the vertebral level is not the same. Okay, so whenever you're discussing in neurology or internal medicine, the spinal level is not equal to the vertebral level. So the vertebral level and the spinal levels do not concord numerically. That is because the growth of the spinal cord lags behind that of the vertebral column. So if you see the adult spinal cord, it ends at the L1 vertebral body. That's why we do the CSF analysis below this to avoid a spinal cord injury. We usually do it around L4, L5. That is because the spinal cord per se ends at the L1 vertebral body. And the lower spinal nerves take an increasingly downward course to exit via its corresponding intervertebral foramen. So that is why it's important for us to know the spinal segment relationship to the corresponding vertebral bodies. So if you see the first 7 cervical spinal nerves, they exit above the same numbered vertebral bodies. However, all the subsequent nerves exit below the same numbered vertebral body. That is because there are 7 cervical vertebral bodies, but there are 8 cervical spinal segments or spinal nerves. So this is a beautiful table in Harrison, which is given the spinal cord level and its corresponding vertebral body level. Okay, so we're talking about the spinal cord level, the corresponding vertebral body level. So if you see in the upper cervical cord, it is same as it has almost the same concordance with the vertebral body. Lower cervical, you'll have to add 1 to get the vertebral body level. We see the upper thoracic, the vertebral body level is 2 levels higher. In the lower thoracic, it is 2 to 3 levels higher. The lumbar spinal cord level corresponds to T10 to T12, and the sacral spinal cord level corresponds to T12 to L1, and L1 where the spinal cord ends. Okay, so whenever you're localizing a spinal cord case, you should be careful whether you're commenting on the spinal cord level or whether you're commenting on the vertebral level, because most of the times, other than an upper cervical lesion, they are not concordant. The exiting spinal nerves exit via the intervertebral foramen of the corresponding vertebral bodies. But if you take the spinal cord segment per se, it does not numerically correlate with the vertebral body level. That is because the vertebral body growth and the spinal cord growth is different. Okay, it lags. The spinal cord growth lags behind that of the vertebral body growth embryologically. So how do you localize a spinal cord lesion? So you can localize it based on the level of the sensory involvement, as well as the level of the motor involvement, as well as the level of the reflex involvement. So when it comes to localization based on the sensory findings, so always in spinal cord, remember that you will have a clear-cut sensory level. So the patient will categorically tell you that, sir, I cannot feel, sir or madam, I cannot feel below this level. So if they're not able to feel below the umbilicus, the sensory level is at T10. They're not able to feel below the nipples, it's T4. So as simple as that. So there's a clear-cut sensory level. And this sensory level, remember that it's a little bit different when it comes to the spinothalamic sensation, that is pain and temperature. So when it is a unilateral cord lesion, it signifies the involvement of the contralateral spinothalamic tract 1 to 2 levels higher. However, when it is a bilateral lesion, the spinothalamic tract is at the same level. That is because the spinothalamic tract ascends 1 or 2 levels little bit before it crosses over to the opposite side. So that is why in unilateral lesions, the spinothalamic tract level is usually 1 to 2 levels higher. And other sensations, dorsal column sensations, usually correspond to the same spinal level. So when it comes to the motor localization, it's very easy. So usually if it's a paraplegia, it usually means that it's somewhere that it's L1 and below. And if it's a quadriplegia, there's an upper limb weakness, it takes the localization a little higher to the cervical level. And the patient will have obvious pyramidal signs, like upgoing plantars, increased or exaggerated deep tenon reflexes. Patients will have clonus. They'll have a pyramidal weakness. You'll have spasticity. So you'll have pyramidal signs. That's because of involvement of the corticospinal tract. So weakness in spinal cord lesions is because of involvement of the corticospinal tract. So other clues for spinal cord localization is autonomic dysfunction. So usually the patient will note that there is absent sweating below the implicated cord level, and patients will have significant bowel, bladder, and sexual dysfunction. And another very important thing that you have to closely look for is segmental signs. So segmental signs are basically signs that are present at a particular spinal cord level that tells us that might be the upper limit of extent. So regarding the segmental sensory signs, at the particular area of the level, there will be a band of altered sensation, okay, in the form of hyperalgesia or hyperpathia. And usually you understand that in the spinal cord lesions, it's an upper motor neuron type of weakness. Patient will have spasticity, exaggerated deep tenon reflexes, Babinski sign. But at the segment of involvement, the patient will have segmental element signs. So how can you get element signs in a spinal cord disease? That is because the spinal cord has anterior horn cells. So at the level where it is involved, those particular anterior horn cells will get damaged. So you get segmental element signs at that particular level, like fasciculations or atrophy at that particular segment. So let's say that you have a segmental level of C8, T1, you'll have wasting and fasciculations of the small muscles of the hands. So that's segmental sign. And at that level, you'll also have absent reflexes. So if you have a C5 lesion, your biceps will be absent, but all the reflexes below that will be exaggerated. Okay, so these are all important segmental signs. Next is when the patient presents with acute severe spinal cord lesion, they might not have all the classical pyramidal signs. They will be in a state of spinal shock. So the patient will present with a flaccid areflexic weakness. So in these times, it's very difficult. So, you don't know whether you're dealing with a spinal cord lesion or you're dealing with a peripheral neuropathy like a GBS. So in that circumstance, it might be a little difficult to differentiate both, whether you're dealing with an element process or a human process. But remember that in acute severe spinal cord lesions, the patient will have flaccid weakness, and it can be quite confusing with an acute element disorder as well. So let's have a look at the spinal cord localization at different levels. So let's say the patient has an involvement at the cervical spinal cord. So the patient definitely will be quadriplegic, okay, because the fibers that are going to the upper limbs and the lower limbs both are involved. So the patient will have a quadriplegia. Initially, if it's acute, it will be a flaccid quadriplegia, but over time, it will convert into a spastic or a UMN quadriplegia. Next is, you have to understand that the diaphragmatic innervation comes from the cervical segments, predominantly C2, C3, and C4. So diaphragmatic weakness can be quite a problem in patients with high cervical cord lesions, patients with high cervical cord lesions. Sometimes the patients can be, they will actually require even long-term ventilation. There'll be a tracheostomy, and diaphragmatic weakness is a important consideration for patients with high cervical cord lesions. Next, the patient can have Horner's syndrome because of involvement of the central sympathetic tract. Next, the patient can have facial sensor loss. Business facial sensing loss, the facial sensations are from the trigeminal nerve. How do you get facial sensing loss in the cervical cord lesion? That's because the spinal nucleus of the trigeminal nerve, trigeminal nerve goes up to the C2 spinal level. So if you see the spinal nucleus of the trigeminal nerve, it dips up to the C2 spinal cord segment. That is why in lesions of C2 and above, you can even have a facial sensory loss. So don't let that trick you into thinking it's a different diagnosis. In all cervical cord lesions, don't forget to higher cervical cord lesions, don't forget to examine the lower cranial nerves and see for any cranial nerve involved. So let's say the patient has a thoracic cord involvement. So here the patient's upper limbs are going to be normal because that is supplied by the cervical cord. So mainly there's going to be a paraplegia. It's either an acutely a flaccid paraplegia, but over time it becomes a spastic paraplegia. So how do you determine an upper extent of a thoracic cord involved? Because if you see, there aren't much of muscles that are supplied. Of course, the intercostal musculature, the abdominal musculature is supplied by the thoracic cord, but they're very difficult to clinically examine. So how do you determine the upper extent of a thoracic cord lesion? Because thoracic cord is all the way from T1 all the way till T12. So number one, you have to very carefully look for a sensory level. So thoracic cord lesions, a sensory level is very, very important because it will tell you. So if it's at the sensory level is at nipples, it's usually a T4 lesion. So at umbilicus, it's usually a T10 lesion. Next, the patient will have bowel and bladder disturbance. And a very, very important clinical sign that should be seen in all spinal cord cases is the Beaver sign. So Beaver sign basically, so you have the abdominal muscles, you have the umbilicus. So you ask the patient to flex their head and try to bring their head up. You see, there will be an upward movement of the umbilicus. So this upward movement of the umbilicus is known as the Beaver's sign. This is because in lesions of T10 spinal cord, the upper abdominal muscles will be intact, but the lower abdominal muscles will be weak. So because of this, the umbilicus is pulled up by the the normal upper abdominal muscles. But remember that even though Beaver sign is relatively specific for a spinal cord lesion at T10, it can be seen in certain other disorders also. So those who are attending it live, I'll put up the answer at the end of the class. Don't worry. You can tell me in which type of neuromuscular disorder, or I'll give you the clue, which muscular dystrophy do you get a Beaver sign? Okay, so this is a very popular Viva question and a very famous MCQ question. In which muscular dystrophy do you get Beaver sign? So just remember that Beaver sign is for T10, T10, and T10. Okay. So whenever you think of Beaver sign, even I never would examine for Beaver sign in a routine muscular dystrophy case. Just saying it for discussion purpose, but remember that Beaver sign is for T10. But for those who are interested, you can put it in the chat box. What is the muscular dystrophy where you get a positive Beaver sign? Okay, so we'll proceed in the class. Those you can put it in and look at the end of the class. Yeah, so that's for thoracic cord. Now coming to lumbar cord localization. So lumbar cord localization, obviously the patient is going to have paraplegia, upper limbs are going to be normal, obviously because the cervical cord is spared. The patient is going to have bowel and bladder disturbance. And depending upon where the lesion is, the patient is going to have different disturbances. So if you have an L2 to L4 lesion, there's going to be paralysis of flexion and adduction of the thigh. And there's going to be a weak leg extension at the knee. And the patient is going to have an absent patellar reflex because the root value of the patellar reflex is L2 to L4. Okay, it's L2 to L4, predominantly at L4. And if the lesion is at L5 to S1, the patient is going to have weakness and of movements of the foot as well as the ankle. There's going to be weak knee flexion, weak thigh extension, and the ankle jerk is going to be absent. That's because the root value of the ankle jerk, is S1. It is S1. And if you have lesions at S2 to S3, you're going to have bilateral saddle anesthesia and perineal anesthesia with a prominent bladder and bowel dysfunction, impotence, and a lax anal tone. And remember that in conus lesions, so basically conus is the lower part of the spinal cord. In addition to saddle anesthesia and bowel bladder involvement, the patient is going to have absent bulbocavernous reflex as well as the anal reflex. And very, very important is in lesions of the conus medullaris, the patient has a normal muscle power. Because if you see, there aren't much of lower limb muscles that are supplied by the S3, S4, S5 myotomes. Okay, there isn't much of motor supply. So if you see in conus medullaris lesions, it's going to be predominantly bowel, bladder, and sexual dysfunction with a normal muscle power as well as saddle analysis. So very easy to remember. So whenever you have a lesion of the conus, you're going to mainly think of bowel, bladder, and sexual dysfunction. Number two, you're going to be thinking of saddle anesthesia. So saddle basically means it's the part of our body that is seated on the saddle when we ride a horse. So it's basically the perineal region. So saddle anesthesia. And very, very important, normal muscle power. Okay. So this is all features of a conus medullaris lesion. So how do you differentiate a conus medullaris lesion from a cauda equina lesion? Okay, so you have to understand that cauda equina is basically involvement. So you have the end of the spinal cord, which is the conus. And from here, you have all the lower nerve roots which ascend all the way down to exit via its corresponding intervertebral foramen. So when you have a lesion that is involving these nerve roots alone, exiting nerve roots alone, it's called a cauda equina. When it involves the conus per se, it's known as a conus medullaris lesion. So let's say how you differentiate. It's important to differentiate is sometimes they can mimic each other. Okay, there can be some overlap. So we'll see what are the clinical points to and against a cauda equina versus conus medullaris. So cauda equina, remember that it's usually asymmetric and it's very, very significantly associated with severe pain. Okay, remember that whenever you have a root localization, it's always equal to pain, pain, pain. I think most of us might have slept the wrong way. We get a neck pain that's radiating to our hand. So remember that for each segment of localization, there is one specific feature. So for neuromuscular junction, it's fatigability. For myopathy, it's proximal involvement. And with normal reflex. So each part of the neuroaxis has a specific feature which gives us a clue that yes, it might be this. So when it comes to root, it's always pain. So cauda equina is a root involvement, so you're going to have severe pain, and the involvement is usually asymmetric. Similarly, the sensory loss is going to be asymmetric in cauda equina. It's going to be quite patchy. Whereas in conus lesions, it's going to be a symmetric saddle anesthesia, as we just discussed earlier. In cauda equina, the motor deficit is quite profound. Okay, it's quite profound and it is asymmetric. Whereas in conus medullaris, usually there is a normal motor exam. And coming to the reflexes, so as cauda equina is a lower motor neuron lesion, the knee jerks and ankle jerks may be lost depending on which part of the cauda equina is involved. In conus medullaris, usually the knee jerk is spared. Sometimes the ankle jerk might be lost. In cauda equina, the plantar is flexor because it is an element process. Whereas in conus medullaris, it might be extensor because it is an UMN process. Sphincter involvement is usually late, whereas in conus medullaris, it is a common and early feature. So these are the important clinical features to differentiate a conus medullaris from a cauda equina, very commonly asked viva question.